Good evening, everybody, and welcome to this, the third SAM webinar of our series that we're presenting. As you know, these are a small series that we're using in lieu of our London conference. I hope you've enjoyed the one so far, and tonight's going to be just as good. So I want to welcome all those who are joining for repeat viewing and all the new people who haven't seen us before from multiple countries. The format for today is like last time. We've got two keynote speakers, and in between those, we've got quality presentations from people who presented or wanted to present abstracts at our London meeting. The first talk we'll have tonight is from Todd Knight, a research registrar from Birmingham, talking about insights from those two keynote papers. Then we've got our first two abstract presenters from Harry and Killem. Then we'll have a short 10-minute break, followed by our second keynote speaker, who's an academic anaesthetist from Manchester, Norman Wilson-Baig, who's going to talk us around conscious proning. We'll then wrap up the evening with three further presentations, two of them live and one on video. When we're in the talks, please feel free to submit questions using this question and answer option, the Q&A. Please put any questions there. If you submit them, we will answer them at some point. It may be orally from the speaker, it may be typed later on, but we'll try and get an answer to everybody. We have got a poll to use, and we'll be asking you a few questions before we start. So we'll have the first question if we can. So can you just fill in this so we know who's here? First of all, can we have your current role, what your grade and job is? And so far we've got roughly half consultants online and a smattering of others. It's nice to see physician associates and nurses joining in and some others as well. Second question is, what is your specialty? So please fill this in and let us know where you all work. And unsurprisingly, most of us online at the moment are acute physicians, but we've got a few other people, including primary care, nice to see some students, and some interlopers for emergency medicine. So the next question is around the subjects. Next two questions around the subjects tonight. So how do you rate your current understanding around the papers, the ISERIC data and the ICNARC data? You've got three choices. So people aren't too confident with it at the moment. And our last question. What's your current understanding around conscious proning during COVID-19? And a little bit of confidence there. So just to let you know what the format for tonight is, each of the keynote speakers will have 15 minutes to talk to us, and then we'll have 10 minutes of questions and answers. The other speakers will have roughly 7 minutes, followed by a few minutes of questions. We will try and keep very much to time. You'll notice there's also the chat function at the bottom of your screens. Use that for any interesting gossip, saying hello, let us know who you are, but try and put your questions in the QA box so we don't lose them. So without further ado, I'd like to thank Todd Knight for stepping in at the last minute to help us today. And he's going to present to us on the ISERIC and the ICNARC data. Thank you, Tom.
Thank you, Nick. Great, thanks for inviting me. My name's Todd Knight. I'm an acute medical trainee up in Manchester, but I'm doing my PhD down in Birmingham. Prior to COVID, I was looking at resilience in healthcare and trying to think of ways to join up literature around viral outbreaks, such as the Ebola virus, with problems in the NHS, like winter pressures, and that problem seems to have solved itself over the last few months. So I'm going to talk to you about ISRIC and ICNARC, and they're two studies that are probably quoted quite a lot at the moment, but people's understanding of them, they might not have a great deal of familiarity with them. There's two recent reports that we're going to go through, but actually one of the key messages is around where these reports have come from, is that they're not acute medicine reports, and really to define the research agenda, we need to be involved in research ourselves. I'm going to present some local data from my trust that we've been working on, and also, again, talk about shaping the research agenda around COVID. So let's talk about ISRIC to start with. So ISRIC is a network of researchers from across 100 countries within an affiliation with the World Health Organization. It was established in 2011, and it works as a platform where research can be conducted rapidly in outbreak-prone infections. And this is done by getting a large amount of CRFs and ethics forms in advance, ready for when an outbreak happens, to do research quite quickly. This research has happened in SARS, in MERS, in the Zika virus, and was ready to roll up as soon as SARS-CoV-2 became a problem. Its focus is very much on clinical characterization and defining the natural history of disease. To enter into ISRIC, patients must have a high likelihood of SARS-CoV-2 infection. And for the vast majority, 98% of patients included in the ISRIC, they are PCR positive for disease. And it only includes hospitalized patients. So these are two graphs from the ISRIC international report. So if we look at the graph on the left to start with, this is the symptomatology of COVID. We can see from the most common symptoms that are right up at the top, history of fever, shortness of breath, right the way through to conjunctivitis, ear pain as less described symptoms. So there's lots and lots of symptoms that are compatible with COVID. But if we look down at the slide at the bottom, we can see that it's really unusual for these symptoms to present in isolation. So the blue bar chart just represents proportions, with the dots underneath the combinations of symptoms that patients tend to present with. And actually, if you see that the columns that have just got one dot in them are pretty rare. In most cases, COVID is a syndromic presentation with multiple different symptoms. Now, sort of gastrointestinal symptoms are well described, again, rarely in isolation. So it's less than 5% of patients within the ISRIC had isolated GI symptoms as pure, as their only symptoms of COVID. So the UK consortium, the use of ISRIC, produced a paper quite recently. So this was published on the 22nd of May. And this looked at outcomes specifically in hospitalized patients. Now, the mortality in the group was around 26%. And I say that's at least 26%, because a third of patients in the cohort were still in hospital at the time of publication. And that's quite a lot higher than other countries internationally. The median age of death was 81 years old. The rates of ICU admission were relatively similar to other US and European countries, although the ICU mortality was slightly higher. And whether that reflects differences in referral criteria and admission criteria between different healthcare systems is difficult to establish, but it's likely to be a big part of that effect. Around 55% of patients were on high flow oxygen. Around a quarter of patients admitted to hospital had no major comorbidities, but the comorbidities that were well described were COPD, type 2 diabetes, and chronic cardiac disease. So I don't know if this diagram quite survived the transition from Keynote to PowerPoint, but this is ICNARC. So ICNARC's collected all the time, but they're releasing reports of aggregated data, I think on a monthly, weekly basis at the moment. It's characterised by 4 data collection points. It's patients as they're admitted to the intensive care unit. There's data collection after 24 hours. There's a 3rd data collection point at the point of ICU discharge, and again, hospital discharge. So I think the first thing to notice about both ICNARC and ISARIC is that this isn't necessarily, these aren't acute medicine studies or evaluations. It's entirely possible that patients that are reported through ICNARC have never been on an acute medical unit at all. The bit between hospital admission and ICU admission isn't covered in the data collection. So the different things that came, well, first of all, ICNARC itself takes data from England, Wales and Northern Ireland, but not Scotland. 289 units contribute. The most recent report is of 12,000 patients, or 12,000 admissions over 9,347 patients. Again, it's confirmed COVID-19, and the most recent report has outcomes for 8,000 patients. There's comparisons made within the report between non-viral COVID pneumonia from historical data, and also comparisons with census data from 2011. So within the most recent ICNARC report, ICU mortality was extremely high, so at 43%. The median age of patients admitted to ICU was 60, and the median length of stay was 11 days. And again, all these were higher than were reported with standard viral pneumonia. Around 3/4 of patients were intubated, and the period of intubation tended to be for quite a significant period of time, 12 days. But really the starkest thing that came from ICNARC and really started to ring warning bells for many was the big disparity in outcomes between different patient groups in ICNARC data. And this was the first warning bells of some of the complexities around COVID-19. So I'll just give a second to look at this graph. So this is in blue, patients that are admitted to ICU, the proportion of patients that are critically unwell admitted to an intensive care unit, with in orange, the proportion that population makes up of the local population in the census data. And there's huge disparity between patients admitted to ICU, massively over-representation by patients who are Black, for Asian or through minority ethnic groups. And this disparity is not just patients admitted to the intensive care unit, but there's actually huge disparities in mortality. So this is a report published by the Department of Health yesterday that looks at mortality from different groups compared with baseline levels of mortality from historical years. So this is mortality from the 20th of March to the 7th of May, going all the way back to 2014. And what you can see in the sort of higher bar of the two shows just baseline mortality with the bar with two-tone colours, mortality since 20th of March. And as you can see, there is excess mortality, both COVID and non-COVID deaths have gone up increasingly, but the difference is not equal between ethnic groups, with excess mortality far greater in Black and Asian communities. And that's true of both males and females. So this difference is quite stark, and it poses all sorts of questions as to why this is happening. And lots of different theories have been postulated, whether this relates to genetic or biological differences or is simply a reflection of other healthcare inequalities really isn't clear, and certainly needs to be unravelled with more detailed observational studies. But this is something that we really need to work on and try and understand what's going on. So, to put in summary ISARIC and ICNARC, ISARIC gives a really good case definition and symptomatology ICNARC tells us a little bit about severe disease and those requiring organ support. But neither of these studies were really conceived with the front of door in mind. And unsurprisingly, they're not really optimized for giving us information for decision making in the acute medical unit. Things that are really important for, well, I think are really important for us working at the front door is risk stratification and prognostication of our patients, tailoring interventions, and also identifying efficiencies in the processes of care. And ISRIC and ICNARC aren't really tailored to do either of these two things. So let's just think a little bit about what acute medical research should be aimed at. So this is from a blog post by Paul Farkas, who's one of the things that irritates me most is how good foam ed is for the ED doctors. And I read a lot of it, and this post was particularly good. Essentially, when we're seeing patients, we're able to classify the severity of their disease at that point, which in COVID raises problems, particularly because we know that it's a multiphasic illness with clinical stability earlier on, followed by deterioration later on. And ideally, what we want acute medical research to do is focus on this red line here. The idea of identifying some way of risk stratifying before patients get so sick, such that we might be able to escalate monitoring, escalate treatment, and make better tailored decisions. The type of the ways that we can do this, there's a reference at the bottom there to a paper which is a risk severity score used in China that's been derived but not validated, that looks at the product of lymphocyte and neutrophil count, D-dimers, CRP, which does have useful information. Really interesting is the use of point of care ultrasound, and that's something that I'm a big advocate of, but knowing exactly where its places in this is yet to be truly established. But acute medicine research needs to be working in this area. So over at Sandwell and West Birmingham, we've been putting together a patient registry to try and answer some of these questions. So we've been doing a service evaluation. We've got about 1,500 patients included so far. It's inclusive of all patients that are assessed on the COVID care pathway. I think that's a really important thing for thinking about this type of research, is that the research to date has all been very much focused on patients that have PCR positivity and confirmed COVID, whereas actually in our patient population, things aren't quite as clear cut as that. I think patients discharged directly from the ED are an important group to think about, particularly in terms of risk stratification. We've taken an approach that's quite similar to SAMinar. We're evaluating the processes of care and looking at 7-day outcomes. So we're very early in that analysis at the moment, but I was just going to share one or two little slides with you. The first is a look at mortality, PCR positivity, and the chest X-ray. So this is a bar chart with three bars showing the 7-day mortality in patients that are in green, which are PCR positive patients. In orange, patients that have chest X-rays highly suggestive of COVID pneumonia, but are PCR negative, and patients that are PCR negative with indeterminate chest X-rays. And the mortality is increased across the board. It's not just patients with PCR positivity that have excess mortality. Now, one of the first things we think about with risk stratification is the use of physiological observations like the News score. Now, I think everyone has one or two reservations about the News score in terms of risk stratification in COVID, particularly with silent hypoxemia and these risks. And at first look at this graph, I just felt quite reassured that it was stacked up in just the right way. Those with low scores had lowest risk, those with higher scores had higher risk. But it's pretty much clinically useless. In patients that have positive PCR, even if you have a News score that's very, very low, the mortality is 7-day mortality is around 10%. That's much higher than in other contexts. So really, it doesn't help your clinical decision making a great deal. Again, similar for the curve score, low risk curve scores, extremely high risk in this cohort. So the mortality is around 20%, even those with curves of 0 and 1. And finally, I think an important part of the process of care is those admitted from institutional care. We had 125 admissions from this group. They tended to be older, they tended to have high degrees of frailty, a high proportion were PCR positive, and the 7-day mortalities were extremely high. And are there ways in which that we can offer the similar type of care outside the hospital environment? So in summary, that's just a very quick skim over some of the most recent observational data. The first phase has been around case definition and looking at outcomes. What we really need to start thinking is how we make this into acute medicine zone, looking at risk stratification, looking at how we target treatments, and more how we deal with patients that have complications from COVID and present later on with sequelae of the COVID disease. We have to be at the forefront of informing this research agenda and using the SAMinar methodology to really get under the hood of what's going on. I don't expect anyone else will do that for us. It will have to be for us to do ourselves. Thank you.
That's really great, Tom. And I suspect you know that Dan Lassemussen has actually probably taken your data set, and we are going to be doing it as a COVID SAMinar in the very near future.
That's fantastic news.
So we've got a few questions coming in already. First one for you from Mike down in Bournemouth. It says, what do you think is the one key piece we as acute medics need to take away from these and your own data as it stands at the moment?
It's a really good question. It's none of it, knowing what part of this is relevant to your acute medical decision making on the front door is really difficult, because knowing all the data to date, the observational data tells us about what the prevalence of different comorbidities is. I don't really see a lot of that helping with front door clinical decision making. I don't think there's anything that really guides a lot as to how you decide that whether a patient that you're seeing at the front door should be going home or staying in. People have put a magic number around SATs of 93 to 94%, and that seems to be where there's a lot of equipoise. The truth is, a lot of my argument here is that we don't have good data to base our decisions on at the moment, and we need to push forwards with that rapidly.
Something that someone's put in, I think this is what they mean by the question. Do you think the false negative PCRs that we get affect this data in any great way?
Yeah, well, it's difficult. I think that the PCR test is not positive, is not perfect. Whether it reflects how the test is taking it at the wrong time. The test will never be perfect, and I think we have to see that patients that this group is at risk of COVID and manage the process like that, in the knowledge that we will never get a perfect test. So I think it does affect the data, but I don't think holding out for a perfect test is ever going to be the answer.
No. And do you think that we'll ever get to a point, given the course of this disease, where we'll have something that correlates to sort of the curve 65 for COVID patients, taking into account things like perhaps BMI, ethnicity, oxygen requirements at baseline? Do you think we'll ever have somewhere that gives a mortality risk score?
I think so. I think that the generating the observational data together that's like this, I think that's what everyone's aimed at doing. I think the integration of point of care ultrasound into that score will be really useful. It's simple, and if that can be done without chest X-ray, without bloods, can be risk stratified. All of a sudden, some of the care of these patients can be moved from hospital to community. And
do you think we'll ever get to a place where something like this is going to be useful for primary care to help them with this?
I do, and I think that's not just predicting risk of death, but predicting risk of escalation of oxygen beyond low flow oxygen. I think if we could get there, we knew that we could identify groups of patients that would need low flows of supplemental oxygen at low risk of deteriorating further. That could be a game changer, because the care could be, if the infrastructure would there, is feasibly delivered outside the hospital walls.
And we'll leave the last question for this one down to our president, Sue. Says it was interesting from the early data you presented that anosmia, sort of smell and taste, were right down at the bottom of the list there. We know the government excluded it for a long time, then it suddenly jumped into the diagnostic criteria a week or so ago. What do you think of, where do you think that all came from?
I think the case definition has to be as sensitive as possible. How useful the case definition is when you're trying to delineate people into hot and cold streams. I like that slide that shows combinations of symptoms are important, because it's quite often you'll take a referral that doesn't sound like COVID, and then it'll be, but they've got a cough. And when you're in that grouping of symptoms that is just one symptom that sits on its own without much else, the likelihood of COVID tends to be much lower. So I think that's quite a useful bit of insight. It tends to be syndromic with multiple symptoms rather than in isolation.
Yeah, perhaps they should tell our local ED that think everything is query COVID, even a pleural effusion is query COVID, but we have to use this data this way. Well, thanks again, Tom. I know we dropped you in it right at the last minute, but it's been a fantastic talk, and thanks for doing it for us.
My pleasure. Thank you so much.
So, moving on, we've got the first of our presentations now from people who have submitted work for our London meeting. The first one is from Harry Willis, who's an acute medic, who's working in acute medicine. He's actually an anaesthetist moonlighting with us. And his talk is developing multidisciplinary high fidelity in situ medical emergency simulation training in an acute medical unit. I'm just wondering what his acronym is going to be.
I daren't fathom. Thank you very much, Nick. And yes, thank you also for identifying me as the interloper in the group. But thank you very much for having me. My name's Harry Willis, representing the acute medical unit team here at University Hospitals Birmingham. And we wanted to present this this work that we did within our unit, because we think it's probably quite transferable to a lot of you. Essentially, we're looking at the management of medical emergencies in the acute setting. We know that being in charge of high acuity areas, we see a high incidence of medical emergencies, whether these be cardiac arrests, near arrests, or simply emergent clinical scenarios. And certainly on our unit, we had a couple of adverse events surrounding the management of medical emergencies here on the unit, that on reflection revealed that there were issues both with our processes, our departmental processes for responding to and intervening in these emergencies, and also the performance of both individuals and the team dynamic as a whole. And we looked to in situ simulation as a modality for improving this for a couple of reasons. Firstly, as a lot of us will be familiar with, in situ simulation, as with all high fidelity clinical simulation, improves both technical and non-technical skills at the provider level. But a less recognized and less well used function of in situ simulation is in systems testing, and it can reveal latent errors in healthcare systems in a dismounted environment, in an environment that's not live and that doesn't have the potential to cause any patient harm. So here on the unit, we distributed a preliminary survey among both medical and nursing staff, which was well responded to and established a very clear demand for emergency training, particularly multidisciplinary training that they felt was lacking from the department's sort of educational programs. We then ran 3 unannounced high fidelity simulations in situ on the unit. and identified issues within the department and with our responses as a result, which I'll touch on later. And we then took feedback from those unannounced scenarios, and we used them both to improve the medical response model on the unit, but also to develop a weekly educational program of formative in situ simulation training. So that's sort of the crux of this work. We're using in situ simulation not just as an educational tool, which we then did develop subsequently, but primarily in the first instance, it was to run these scenarios in the real environment and identify problems as they arose before they arose in the case of a real patient emergency. So what did we find? Well, in the preliminary survey, the common themes you can see here, the most sort of profound were a sense of sort of gross disorganization. We have a very well-staffed unit at all levels, both medical and nursing, particularly during normal working hours. And the resultant menagerie of staff that emerges whenever an emergency buzzer is sounded, combined with a perceived deficiency in the establishment of a command and control role, were perceived to be big obstructions to providing good care in the emergency setting. And we then ran, as I said, these 3 unannounced scenarios in situ, covering different emergencies in slightly different environments within the acute medical unit. These did exactly what they were designed to do. They exposed latent error within our emergency response, and also some specific issues related to the department. For example, the availability of lack of knowledge of location or lack of familiarity with critical equipment, issues with interpersonal team working and command and control, as I mentioned before, and also quite low levels of staff confidence as a result of these perceived deficiencies that were recurrent within medical emergency management on the unit. Although these scenarios were received positively both by the departmental leads, both medical and nursing, and also those who were involved in the scenarios themselves, there's no denying that unannounced scenarios are very disruptive towards clinical work, as indeed any ordinary medical emergency is. And the other issue from the educational perspective, yes, we were revealing latent errors within our departmental emergency responses, but we were...
Doctor, just wait, please.
No, excuse me. We were limited in terms of delivering constructive feedback within the scenarios, from an educational standpoint, because it would have broken the fidelity of the simulation and would have reduced the yield in terms of identifying the latent problems that we were looking to identify. Which is why we then took that forward, ceased our unannounced emergencies, and put together a formative educational model, a weekly voluntary session, designed multidisciplinary from the ground up, and this was very well received. Data gathered from pre and post scenario questionnaires from these formative sessions were very positive, and self-reported confidence in managing and, where relevant, in leading medical emergencies on the unit was greatly increased. Although we didn't, we weren't able to gather any objective evidence to show that this improved our medical emergencies management in live, if that makes sense. And as I mentioned before, the systemic issues identified by both of these sets of simulations have been addressed locally. So ultimately, what I'm trying to get across is that in situ simulation is a multifaceted tool in the AMU setting. It's not just an educational tool as we've been conditioned to think. It's also very useful in terms of risk management and identifying unrecognized latent error in the clinical setting. They are perceived as irritants, and as staff irritation goes up, their buy-in goes down and the yield goes down. There's no denying it. So these things have to be managed very effectively if they're to work. The voluntary sessions that we then evolved from our initial sessions, we found that they did increase the participants' self-reported confidence in emergencies management, but it's very difficult to produce objective evidence that team performance is improved, which can be an issue in terms of justifying a quite resource-intensive educational tool. And we did also see collateral benefits from running these sessions. So debriefing following medical emergencies is now commonplace, both medical and nursing led on the unit. And we also found that our internal incident reporting mechanisms showed quite a substantial uptick in systemic issues within the department that hadn't necessarily led to any patient harm, but had been identified and reported. And we were glad to see that increase. Thank you very much for your time. Any questions?
Thanks a lot. That was really good, Harry. We have got a couple of questions coming in. We've got one from Sue, says, the unannounced ones sounded rather stressful. How were they taken on?
Yes, so, I mean, unannounced scenarios, we wondered whether we would struggle with the buy-in and the suspension of disbelief that one would sort of expect to require if one were to get useful information out about what problems staff would come across were it a real emergency. But actually, the buy-in was very good. But as you've identified, if the buy-in is good and the suspension of disbelief is good, then yes, the temperature does get high. We pre-warned staff on the unit, not before each session was to run, but we briefed staff as a whole before this set of simulation sessions was introduced. So people were aware of the modality, what was expected of them, the fact that this was not a summative assessment tool for any individual in terms of their practice and exactly what it was designed to do. But I feel that actually the stress during the scenario often leads to some quite frank and open debriefing. And you know, it wasn't something that we found we had an issue with, but you have to make sure that the scene is set correctly and that people know exactly what the scenario's objective is and what is expected from them.
And a couple of technical questions about how you ran these that come in. First of all, who from the MDT took part, and then a bit more about the timings and how long each one took and how many people you had actually attending. That'd be possible.
Sure. So in terms of the way these were set up, so these were set up with a fairly basic in terms of technical proficiency simulation mannequin and ALS style resuscitation mannequin, set up in a patient side room or a consultation room, or we did one in a shower, for example, to simulate sort of, you know, some environmental obstructions. And we set them up, and then in order to simulate what would happen on our acute medical unit, we pulled the emergency buzzer. And so who from the MDT responded was entirely representative of who would respond on your average day. So it was a fairly, what tends to happen or tended to happen, which was one of the issues identified prior to starting this program, was that every man and his dog, from medical, nursing and you know, domestic staff porters, everyone runs in one direction, sees a huge throng of people, and then more or less everyone spills off But the people we were left with tended to be fairly representative of the people who we'd expect to be at an ordinary arrest in terms of medical, nursing, portering, etc., across a wide variety of grades with medical and nursing. So we let it run sort of organically in that sense. Generally, the scenarios ran for 10 minutes. They were designed to run for 10 minutes with scope for a bit of stretch if necessary, with a 20-minute to 25-minute debrief afterwards. Obviously, the challenge is to manage that in the context of everyone's normal working day. So we had to liaise quite carefully with departmental leadership and things to ensure there was enough slack for us to run these sessions, and certainly had to postpone one or two for that reason, so as not to be too disruptive on a bit of a short day. But that's the way technically those were run. I hope that answers your question.
Brilliant. There are lots more questions coming in, so if it'd be great if you could answer some of the questions like the ones from Liz and Alex that have come in the last couple of seconds. But many thanks for speaking to us. Hope we didn't scare you too much.
Thank you.
So moving on to our second presentation of this pair, we've got Dr. Killem Slinger, who works in Southampton, and he contacted us during one of these sessions to ask if he could present his work, and we've given him a space to talk about the AMU socially distanced.
Thanks, Nick. I don't think these are my slides actually come up yet. But there we go. So my name's Killem. I'm one of the acute medicine registrars at Southampton Hospital, but I'm also one of the education fellows at the Wessex Deanery. And I've been very kindly invited to come and share with you my project that we've started in our department, which I've called AMU Socially Distanced. So first of all, the reason why we created this program in the context of the pandemic, as I'm sure is the case for everyone up and down the country, educational programs have been cancelled and postponed for multiple reasons. However, I certainly noticed in our local team that there was a lot of enthusiasm for continuing teaching and learning, and so it kind of sparked my interest in coming up with a way we could deal with that. Whenever I was considering this program, there were two key features that I needed to ensure were maintained. First of all was that social distancing was accommodated and that the workforce presence was maintained on the wards. Probably the two reasons why our teaching programs were cancelled in the first place. So what I did was I initially surveyed our junior doctor workforce to see what kind of method of teaching they would buy into most. And the two top answers were an educational display in our doctor's office plus a WhatsApp group discussion. I then created a weekly rota where I tried to pair up a more senior trainee with a junior trainee, and then they were free to choose whatever topic they wished to discuss that week. I then disseminate a weekly feedback survey via Google Forms just into the WhatsApp group, which is then completed. It's got a mixture of qualitative and quantitative information on it, and then I send that feedback out to the juniors afterwards. So a bit for the educationalists here, very briefly, the evidence kind of behind my thinking of what we've done. So fundamentally, the program is supported by constructivist social learning theory, and to put that in basic terms, what it's implying is that it's their learning on prior concrete experiences and then able to construct new learning around that previous concrete experience, combining that with the social nature of learning, whereby we improve our retention by discussion and speaking to one another, and in a social environment, it creates quite a powerful tool. It wasn't my intention entirely, but actually a lot of the scenarios, a lot of the weekly teaching have been case-based, and so it really does provide that concrete experience to allow the trainees to attach their new learning to. Furthermore, with near-peer learning or peer learning and flattened hierarchy, it really does ensure that the content is pitched at the right level, and that people feel able to ask questions without fear of judgment, which we do typically see when you've got a more hierarchical teaching environment where you've got a very senior member of staff teaching a more junior group of staff in your typical seminars. And then finally, touching on the sort of self-directed study and adult learning theory, we're all internally incentivized to kind of identify our learning needs. And so the nature of this program, whereby the juniors are able to identify interests for themselves and come up with a topic themselves, really does motivate them to explore their needs and present it in very interesting ways. And then finally, from my perspective, I've been prospectively and continuously evaluating this program rather than a single retrospective analysis, which is often the case with a lot of these sorts of things. So what I've done here is I've just got some pictures to show you of what that looks like. On the left of your screen, you can see our doctor's office with A4 sheets of paper stuck on the wall with some sellotape. It's slightly rudimentary, and I grant you could do with a lot of touching up, but there is interactive elements to it, with lifting the flap to encourage people to think about what they would do next before seeing the automatic answer, and also QR codes to link people to external web resources. Observationally, I have seen lots of juniors interacting with that quite well. And on the right, you can see a snapshot of the WhatsApp group discussion. What was interesting here was that people started talking about topics that are on a slight tangent. So for example, here they're talking about a scoring system and the benefits of scoring systems, but also the limitations and when they're appropriate and when they're not appropriate. Also talking about cognitive biases and clinical reasoning as well, which was a really interesting tangent for people to go down. At this time as well, we actually had other specialty registrars joining us in the AMU. So dermatology reg was actually in this group as well. And they were able to give us excellent insights into aspects of the topic we wouldn't have even considered. So my initial conclusions from this project, we've been running about 8 weeks now. The displays are engaging. People, the juniors are enjoying looking at the display and sort of interacting with it. There's been an interesting competitive nature. Each week the juniors want to try and beat their colleagues from the last week and do a better presentation or think of a new way of displaying it. A big positive the juniors are enjoying is getting formal written feedback, both in the form of the questionnaire being sent out to them, but also I'm offering to do teaching observation forms for their portfolio, and so therefore that ARCP need is ticked for them. And then the WhatsApp discussion has been fairly successful, and I say kind of there because it really does depend on the trainees that are responsible for that week. If they're educationally minded or particularly interested in that topic, then they are posing questions, uploading additional resources, which is really stimulating the discussion. However, if they're not of that mindset, then actually not much does really happen. So that is an area for me to address in the future. And the last 3 points there that I've listed are areas of concern that I've highlighted over the last 8 weeks. First of all, although it is a single survey that takes no more than 60 seconds, it is requiring a bit of prompting on my part to get people to fill it out with adequate response. So there's definitely an element of survey fatigue setting in. On a couple of occasions, some of our consultants in the department have identified incorrect information being displayed, and that's been corrected as soon as it's been identified. I have tried to mitigate that by joining the senior and a more junior trainee together, and also screening it myself, but I can't be perfect every time, and so it is something we are mindful of and I am asking to be monitored. And then finally, sustainability. The rotational nature of my job being a registrar means I move on in August, and so this programme would not continue if at the moment if I didn't stay. So I do plan to kind of share this plan, this idea with the departmental lead for education to see if it's something they wish to take on. So then my final slide is what I'm doing next. I'm sharing my practice. That's why I'm here to share it with you. I've been putting it out on Twitter and sharing it with colleagues, and I think some trusts around the country have been starting to use it. I need to consider sustainability and address the survey fatigue, as I've just touched on. Idealistically, I'd like to improve the materials. An electronic whiteboard with them moving over automatically would be wonderful, but is obviously very costly. And then finally, formal peer review and considering getting somebody external to look at the programme and see what they think. So I'm very happy to answer questions and be contacted about the programme. It's something I'm very enthusiastic about, and I hope you found it useful. Thank you.
That was really, really good, and your enthusiasm shines through. I think it's partly that got Dr. Crossland contacting you and press ganging you into talking tonight. But thank you very much. Is it more of a comment from one of the people listening? Isn't it that learning and things are just innately happening at the moment, but this sort of thing just makes it much more concrete?
I think I don't know where I really stand on that opinion, because I have to say I think we do fall into the crux of just assuming learning is happening, and it does to a certain extent. But I think that can sometimes be used as an excuse to not innovate and create new educational programs. And actually, train up the trainees, if you like. And, you know, of course, there's a degree of workplace learning, but I think it's always nice to show that you value the trainees by giving them the opportunity to do these sorts of programs. And
someone else has said that this is really good, and in one way sort of mimics the things that people often put around their blood gas machines, the 1 minute.
Exactly. It's exactly that sort of thing. And, you know, it's probably where the inspiration came from. I've just maybe formalized it a bit more into something a bit more in depth. I think it's just, it makes a change from the standard seminar style teaching where you've got that didactic relationship between a lecturer and your group, which we all sit around having our drug sponsored lunch with, falling half asleep in the middle of the day. So I think this is nice because it allows learning to continuously occur throughout the week, rather than a single 30-minute slot.
And I'll ask the very last question in this bit. Have you moved on to engaging the AHPs and nurses or the PAs in any of this to broaden the aspect?
So we have a couple of ACPs in our department, both of which are included in the group. Extending it to the wider MDT hasn't happened. As I said, the display is currently in our doctor's office, which people are welcome to come into as they like, but it's probably not accessible to the MDT, and it is something that may be worthwhile considering. You're right.
Okay. Thank you again, and thank you to the first two speakers. Just before you all go on your tea breaks for the next 10 minutes, just like to remind you that the SAM elections are open for nominations. We've got 12 posts up for election. All the details are on the website, so you can find it quite easily. If you want to ask any questions, contact anyone on council. We'll be really happy to give you our views on anything and everything to do with being a councillor or on one of our committees. And we're moving on now with our second keynote speaker, who, as the speaker did last week, has aged me tremendously by telling me he was my houseman at one point. So we've got Norman Wilson-Baig from Manchester. He's another anaesthetist, and this time he's going to talk about the conscious proning we've all been doing during COVID-19. Thank you, Norman.
Hi, my name's Norman Wilson-Baig. I'm an SC6 academic trainee in anaesthesia with an interest in critical care medicine. So I'm going to talk to you about conscious proning during the COVID-19 period. Now, as you all know, proning is a common strategy that's used in the critical care setting. However, there is issue with the cumbersome nature of proning ventilated patients. This includes requiring 6 to 7 people to rotate the patient, the risk of the tube becoming dislodged, and then on top of that, you've got the 16-hour proning period. There's risk of nerve damage, risk of pressure sores that can occur. So there's a good amount of close nursing and medical attention that needs for these patients. However, the benefit of proning in these patients is clear to see, and I'll explain a bit about that later on in this presentation. So naturally, wouldn't it be great if we can get the benefits of proning much earlier on in the condition, and I hope this will give you an insight from this presentation. So I'm going to talk a bit about the background, the physiology and rationale, evidence to date, a bit about the Ics Guidelines, what we're doing here in the Northwest currently, and summarize at the end. So this is a bit about the brief pathophysiology. Forgive me if I'm teaching you to suck eggs here, but this is the traditional ARDS model. We have an insult. It's where the virus can cause an inflammatory change within the pulmonary tree, which causes increased permeability, which causes lung edema, which causes increased lung weight. That in turn leads to atelectasis, which leads to increased shunt and increased VQ mismatch, which in turn leads to reduced ventilatable lung, which therefore increases dead space. And so as you can see, there's like a cycle of destruction that occurs here within the pulmonary tree. The recommendations, or the way we sort of managed ARDS in critical care, is by using lung protective ventilation, by using PEEP to recruit the collapsed alveoli, and by prone ventilation. Now, you could be forgiven if you thought that even COVID-19, the kind of ARDS that we experience with patients attending the ED, would be very similar to what we see in the traditional type. However, this is not the case, and with experience we have seen that there's a different phenotype that, well, these have been anecdotally called the L phenotype. These are your sort of happy hypoxic patients who come in early within their condition. They're sitting in their bed or walking around within the room, happily conversing, using their phone, etc. And so this is a type of dysregulation of the pulmonary perfusion, which has been attributed to pulmonary microthrombosis. So these guys have the low elastance, which is high compliance, low recruitability. That's because their alveoli are pretty much open, and they've got a fairly normal lung architecture. Now, as the issue with these guys is that as the disease progresses and you get increased inflammatory changes that occurs within their lungs, these individuals then progress onto the H phenotype, which is what we're familiar with in the traditional form of ARDS. These are called H-type because of the high lung elastance, low compliance, a collapsed alveoli, therefore they're higher recruitability and they have a higher PEEP response. So what I must clarify here is that they're not two separate entities, but they're a spectrum of ARDS picture here between the L type and the H phenotype. And so it's the person who's coming through the door in the ED, it's unpredictable where on this spectrum they will be. What I will say, and as Gattioni suggested, who's a well-known intensivist with a specialist interest in ARDS, is that when you're managing patients with the L phenotype, these patients require just increased FiO2 and liberal tidal volumes, unlike the H phenotype, which I've described in the previous slide, who need lung protective ventilation, etc. And so I hope this slide sort of clarifies that the COVID patients is sort of slightly different to the traditional type of ARDS. So a bit about the mortality. This information was taken from the ICNARC data. So we've got non-COVID pneumonia versus COVID pneumonia. This was taken from 29th of May last week. The non-COVID data is from 2017 to 19. As you can see here, there's a stark difference in mortality between the non-COVID pneumonia and COVID pneumonia, between basic respiratory support, which is CPAP, and NIV, compared with the advanced respiratory support, which is intubation and ventilation. Now, if I was to show you this slide from a month ago, you would have seen that the advanced respiratory support in the COVID pneumonia group would have been around 66%. However, as you can see, it shows that we're obviously with more understanding of the condition, our management has improved. Obviously, there's a lot more improvement to go. So, what is the physiology of proning? Well, this is a slide to demonstrate that. You've got two pictures here in the supine and prone position. And on the right-hand panels, you've got the transpulmonary pressures and blood flow. So in the supine position, you've got increased transpulmonary pressures within the ventral alveoli, ventral side of the lung, and unlike in the dorsal side of the lung. And so what then happens is you've got this over-distended alveoli in the ventral side compared with the dorsal side. And then, the downside also is you've got increased blood flow going to the back of the lung. So you've got increased VQ mismatch, increased shunt, and so not ideal in ARDS, which actually worsens this position. In the prone position, as you can see, you've got more of an homogeneous transpulmonary pressure. And so what then happens in these individuals is that you get recruitment of the alveoli in the dorsal lung, and you've also got alveoli in the ventral lung, which is open as well. And interestingly enough, blood flow still preferentially goes to the back of the lung, and so guess what? You got better VQ, you got better shunt, or improved shunt, and so hopefully better oxygenation. The theory behind this is evolutionary from our foreparents, as we were primates and we were on all fours, and so the most efficient way to ventilate your lungs was to, obviously whilst on all fours, is to make sure that the dorsal lungs are adequately ventilated, as they have the better blood flow. So the benefit for and the rationale for proning is that you've got recruitment of collapsed alveoli in the posterior lung, you've got improved secretion clearance and improved ventilation perfusion, and you've got reduced shunt as well. So we've seen the evidence for proning looked well in terms of the physiology and what we are doing within critical care. So I thought I'd just quickly show you the seminal paper as to why in critical care we use proning. So this is the PROCEIVA trial, which is the proning of patients with severe ARDS. This was done in 27 centres in France and Spain with a lot of experience in proning critical care patients. The primary outcome was all-cause mortality at 28 days. You can see the data's there. I mean, 16% mortality versus 33 in supine. And you've got the Kaplan-Meier curve on the right-hand side, which shows that in the prone group, the 90-day predicted mortality is much higher than that in the supine group. So the bottom line here is that proning in severe ARDS reduces mortality. However, as I said, it is a cumbersome procedure requiring multiple people to rotate the patient, you know, risk of tube dislodging, etc., etc. So if proning is such a good thing in the critical care, but obviously considering the issues they have as well, wouldn't it be great if we can use the benefit of proning whilst a patient was awake and therefore avoid the need for intubating these patients? So there's limited evidence for this, unfortunately, because let's face it, we always manage patients in a supine position. Scaravelli et al. In 2015 reviewed a retrospective study of 15 patients over a 4-year period. That's it, 15 patients they could find over a 4-year period that underwent conscious proning. And from those patients, they found that 12 patients were discharged and 3 unfortunately died. Then there's Ding et al. In 2020. Now this was pre-COVID, and this actually tried to give it some sort of a formal study to it. It's a cohort study, but this looked at conscious proning with high flow nasal cannula or NIV in combination as opposed to conscious proning on its own. And over a year between 2018, 2019, they recruited 20 patients and they found that 11 patients avoided intubation. And if for those who'd like to know, NIV plus conscious proning did the best, while high flow nasal cannula came at the bottom. The downside to this study is, like, I mean, although those 11 patients avoided intubation, which is great, the 9 patients that didn't avoid intubation actually had PaO2, FiO2 ratios of much less than 100. They were around 50 to 80. And so my feeling is that these people would have missed the boat with regards to conscious proning, because their ARDS at that point is quite severe, especially with the values below 100. And then looking at the COVID era, you've got Sun et al. In 2020, who from the experience of Jiangsu province, described that people who avoided intubation were those that actually they referred for conscious proning, and so they recommended conscious proning. And then there's Capito et al. In 2020, who recommended, who by necessity, conducted conscious proning in 50 patients in the ED, with the large number of patients arriving in the ED and the resources that were limited. And in their experience, 32 patients were successful and avoided intubation. And these were patients who they felt would have gone down the roads of intubation. And so in their experience, they feel that conscious proning is a method to be considered. So these led us to the Ics Guidelines, because there was an increase in appetite in the use of conscious proning. And so we've got here produced was the FiO2. We looked at patient selections is very, very important here. So the FiO2 we went for was at least 0.28, 28% oxygen, unlike previous studies which use 60% oxygen. Why consider proning when someone is on sort of higher oxygen levels, and the next level above that is a non-rebreathe mask? So we went for a lower oxygen requirement. Then it's important that these individuals are able to reposition themselves, able to communicate, because unlike the ICU, they're not going to get one-to-one nursing on the ward. Then the absolute contraindications are respiratory distress, obviously not going to make somebody conscious prone with a rest rate of 50 plus. And then relative contraindications, the one sticks out is pregnancy, but they can lie on the lateral. And then once they've agreed to conscious prone, then we look at the timed repositioning. Now this is table 1. As you can see, the timed repositioning was considered within the DING study and also the Capito study. Let's face it, I challenge the most ardent person to try and sleep on their tummy for 16 hours. Unfortunately, there isn't a consensus on how long a patient should be prone. This is obviously being deduced with a meta-analysis, I think might be published next year. So we went with 2 hours fully prone, then lying on your right side, then left side, and then prone again. And the whole idea is to avoid lying supine because there's uncertainty on the sustainability of oxygenation in the supine position. And so as you go on, you monitor the oxygen saturations in a particular position, and should they fail, then you can reposition them, or if they are deteriorating, then further help should be sought. So what are we doing in the Northwest? Well, in the Northwest, we're taking a pragmatic approach to that, looking at doing a prospective audit, examining the effect of conscious patients, and we're looking at the avoidance of intubation. We're looking at reduction in basic respiratory support, and FiO2 that's required, safety outcomes, we're looking at the tolerability in those positions. And currently we have 70 patients that have been recruited so far. In another study, there's a French study looking at the which is ProCov study, looking at a single center which are recruiting 25 patients, and we're awaiting their results. So to summarize, we can see proning is established in critical care and is very useful in managing ARDS patients, but the physiology suggests, although limited evidence is there, suggests that this is related to conscious patients as well, and hopefully would avoid intubation. Early evidence is that, as I said, it improves oxygenation, but we're uncertain about the sustainability when supine. Further studies are clearly needed, and obviously this is something to consider beyond COVID. I'd like to thank Dr. Andrew Bentley for kindly reviewing the slides, and also the Northwest Regional Group and Intensive Care Society for the publication of the guidelines, for which I'm one of the authors. These are the references. Thank you so much.
We're moving on to our first of our next 3 presentations. We've got someone speaking to us, then a video, then another talk. First up, we've got another education slant. We've got education training as a key driver for improving fluid balance monitoring and documentation, a QI project presented by Alpha Madhu from Kettering. Thank you, Alpha.
Yeah. Hi, hello. Good evening, everyone. My name is Alpha, one of the Trust Grade Senior House Officers at Kettering General Hospital. This is a QI I did with my colleagues, and it's on fluid balance monitoring in the wards. So the aim of what we are trying to do was, obviously the rationale was, we noticed that fluid balance charts were poorly being recorded in the wards, and we also noticed that this was not just limited to a hospital. It's also in the literature and in other people's experiences. So we wanted to know how accurately and completely these charts were being recorded. I wanted to see if there were any challenges that the nursing staff had in using these charts. So we tried to also make some recommendations for that. So what we did, we used the PDSS cycle in simultaneous cycles. We used the questionnaire to assess the charts for quality, and then we put in place some interventions, and then we took 2 more cycles of data after that to see if there was any improvement. So we had 7 parameters we were assessing. We wanted to know if the measurements on these charts were accurate and if they've been summed up for the day. Wanted to know if the sums were also correct. Wanted to know if fluid balance recording was indicated in these patients. Wanted to know if the time of entry was indicated. I wanted to know if the writings were legible. So we're just basically trying to find out where the problem could be. And we also took some data from nursing staff to know what kind of challenges they face. So most of the staff we had, most of them actually 3 out of 11 had only received training on how to use a fluid balance chart, so the remaining 8 had not been trained. Other ones reported that fluid balance charts were being used excessively in the ward, even in patients that didn't require it. Some others complained that there was poor communication how to use charts. Sometimes, even when using charts have been indicated, there's no communication from the doctors on when to stop using these charts. So what we had was that patients that had even been declared medically fit and were waiting for discharge were still monitoring their fluid, balance. And then they had difficulty also in, recording the fluid inputs and outputs of patients that were ambulatory, young patients in the ward that could walk to the loo themselves. So it was difficult to track their intake and output. So what we did regarding the overuse of charts, we discussed with the doctors on the wards and let them know to, indicate when these charts are necessary, so that we're trying to stop the practice of everybody being on the fluid balance charts automatically once they're admitted. So we spoke with the doctors and the wards so that they can clearly indicate in the file, when they want this chart started, what exactly they want to be done, what are the fluid targets, and whenever they want to stop, they should also indicate. And then we discussed with the nurses also. So we held one-on-one discussions with the nursing staff, and we gave them some form of training on how to properly record in these charts. We also designed some handbills and we distributed to the nurses. We distributed those handbills also all around the wards, so that's helped. And then we noticed that many of them had problems with in patients that we are using on incontinence pads, so the ones that were not on urinary catheters. There was a lot of problem in measuring their input and outputs, especially the urine output, because they had this practice of writing up things like peed or pooed, in the fluid chart. So that was a problem also. So we provided weighing scales in the ward so that they could, accurately measure the outputs of these people. And then for the ambulatory patients, we tried to get them to record their own input and output so that, the nursing staff could then transfer those recordings into the main charts. So this is just a sample of a flyer we made on the left-hand side. So over here, these are the posters we made and we distributed them in the wards. And this is an example of a chart. I don't know how clear it is. So you can see how empty it is and a lot of wordings on it and quite ineligible. So this, see, no total has been put. There's no output, nothing. So this is how most of the charts actually look like. So in our results, these black bars represent our first data collection before we did the interventions. So, we measured, as I mentioned earlier, the accuracy of the measurement and all that. So these are the black charts. And then the next color is about 2 weeks actually after intervention. So we took another set of data and we can see there has been some improvements, actually improvement in all the parameters we measured. Now, time of entry is constant because in my hospital on the charts, the time is indicated on the fluid balance charts. All you have to do is to put in the figures. So that's always going to be constant. So we noticed that there was improvement. This was roughly 2, 3, 4 weeks after we took, we did interventions. This was done sometime at the end of last year. Now we waited about 6 months again before we took another set of intervention. And the aim of this was to look for, we're trying to check for sustainability. Has this been sustained? Unfortunately, this coincided with this COVID period, which I don't know, in my own clinical practice, it's, there's been a lot of changes and things are not really being done as properly as they used to be. So that's why it does account for these, drop in the statistics we had. And we can see whether it's clinically indicated is completely zero here. So we just noticed that nobody indicated again if they wanted these charts recorded or not. So that accounts for the drop in the parameters this period. But we're able to show this increase the first time and we presented it to the hospital and we're trying to roll it out trust-wide now. What this QI has shown is that education is quite important in improving how fluid balance charts are recorded, and we can involve patients in their own care also. We don't really have to go too much to technology, to resource technology to help to resolve this. We noticed that it's just poor education, among the nursing staff, and we noticed that they didn't have any proper formal training in our hospital on how to use these charts. And with the little we did, we're able to show that there was some improvements. So the hope is that after the COVID period, we'll try to organize more formal training sessions for nurses and healthcare assistants in my hospital and try to roll it across other wards and then see how much it can be sustained. So that's exactly what we've done, and it's still being worked on right now, just that it's been at the pause now because of the COVID issue we're going on now. Thank you very much for that.
Thank you very much for presenting your work. I suspect it's a problem that's common in many, many hospitals, certainly is in our hospital, and we've got electronic records which seem to be even harder to fill in and interpret than the old paper ones. Have you worked anywhere with electronic records yet?
No, I've not worked anywhere with electronic records for fluid charts, but right now in my hospital, they're trying to switch to that, but that's also been slowed down because of the COVID crisis. However, where they invited us that did the QI to, the team that was trying to design the new electronic record. So what we're trying to do was to try and make it as simple and easy to use as possible. But again, we had challenges with that, but that's still in process.
I think that's a key, making all of this as simple.
Yeah. However, even with electronic methods, we found out that the most important thing is they need to be properly trained on how to use it, because the only thing electronic method is going to do is, that you're keying in the correct figures and is doing a proper addition. But, getting the correct weights out of the incontinence parts, being meticulous and recording the inputs and the outputs, that's all human now. So it's the training that is lacking. And we noticed that there was people, we took it for granted in my hospital that, they should know how to do it. But when we did this inquiry, we found out that most of the nursing staff actually reported that they didn't have any formal training on how to do this.
I don't know, it might be an idea. I've always suspected that the pediatric wards measure fluid balance much better. Did you go and have?
That's right. So we noticed that pediatrics ward, cardiology ward, even hematology ward in my hospital, and nephrology, so they were more meticulous. So we found out, because we did this study on a general medical ward, so we found out that it was actually a training program. Those nurses in those wards have been more, better trained than the ones in the general medical wards.
Okay. And what's your next move in this? What's the next thing you're going to do?
So the next thing is, we're trying to design a training module that can be rolled out to all the nurses. Unfortunately, we're facing challenges with that because a lot of the nursing staff are not regular or permanent with the hospital. So many of them come in and go. So we're trying to see how we can capture them in. We've presented this to the hospital management, and we're just working on modalities with the senior nursing staff on how to roll this out. So it's all training. We're trying to see if we can put it amongst their competency skills, and then, constant training and retraining on how to properly fill in fluid balance charts.
Okay. Well, thank you very much for taking the time to present your work to us, and good luck taking this on further.
All right. Thank you.
Right. Our next presentation is a pre-recorded video from Zishan Javed, who's a trust doctor at the County Durham and Dighton Hospital, and his presentation is entitled HIV Infection Masquerading as Connective Tissue Disease. If there are any questions you want to put to him following this presentation, please leave them in the Q&A box, and we'll email them to him later and try and get a response from him. Thank you.
Hello, and a very good evening to all of you who have joined this SAM webinar. My name is Zishan Javed. I'm working as a trust grade doctor in Darlington Memorial Hospital. I'm going to present a case report today. I would like to mention the name of co-authors of my case report, Dr. Anupam Paul, who is the consultant rheumatologist working in James Cook University Hospitals, and Dr. Babita Mikhail. She's working as a rheumatology registrar in James Cook University Hospital. As you can see, the title of my presentation is HIV Infection Masquerading as Connective Tissue Disease. So this case is about a 56-year-old lady who worked as a housekeeper, and she was referred by the GP to rheumatology clinic with a variety of symptoms. She had gradual onset of erythematous reticular rash on her lower limbs that started 6 months ago. She also complained of some chronic intermittent symptoms of recurrent oral ulcers, Zika symptoms which include dry mouth and dry eyes, profound fatigue, paresthesias in both of her feet, arthralgias, and low mood over the past 1 year. She did not complain of any systemic features like fever, night sweats, or weight loss. There were no inflammatory joint symptoms. She was not a smoker. She was not an alcoholic. At the time of presentation, she was single with 3 children. She was independent with her day-to-day activities. And it's worthwhile mentioning that there was no family history of any cancers or any rheumatic or connective tissue diseases. When she was examined, her weight was 58.5 kg. Her BMI was 22, which was within the normal limits. Blood pressure was 146/73. She was noted to have a livedo reticularis rash on both of her legs up to her knees and on both of her elbows as well. There was nodal osteoarthritis noted in both of her hands, but there were no features of any peripheral joint synovitis. Rest of the systemic examination, including the cardiovascular, respiratory, abdominal, and neurological examination, they were unremarkable. She had a urine dipstick done, which showed a trace of leukocytes, positive nitrates, positive trace of protein, and blood. A culture was performed which showed E. coli, and she was treated for a UTI based on the sensitivities. So her investigations showed quite a few interesting things. She was mildly anemic, mildly lymphopenic, and thrombocytopenic. Her Coombs test was positive, but her serum haptoglobin level was reduced. Her iron levels, vitamin B12 and folate levels were normal as well. ESR was raised at 77, and she had hypergamma-globulinemia with a polyclonal pattern. Also, her urine protein creatinine ratio was raised with a low C4, and then an extranuclear antigen, which is commonly known as autoimmune screen. It was positive for ANA, it was positive for anti-RNP antibodies, and it was equivocal for anti-Smith antibody. She had nerve conduction studies done, which showed a mild axonal mixed sort of neuropathy. Rest of her investigations, including the electrolytes, bone chemistry, renal, and liver function, they were normal. Chest X-ray and echo were unremarkable as well. So, based on her SLE-like clinical features and hematological abnormalities, her strongly positive ANA, a positive anti-RNP, and equivocal anti-Smith antibodies, a diagnosis of mixed connective tissue disease was made. We know that mixed connective tissue disease is an overlap syndrome, which includes features consistent with SLE, scleroderma, and polymyositis, though in this case there were no features of myositis or scleroderma. But the overall picture, it suggested more like a mixed connective tissue disease. She was commenced on hydroxychloroquine, but she stopped it shortly because she developed some floaters in her left eye. She was given a trial of steroids as well. It was methylprednisolone injection. 4 months later, she mentioned there is no improvement in her symptoms after getting the steroid injection. Later on, she complained progressive worsening of discomfort in her feet, significant fatigue, and she was tearful most of the times. She was reviewed by a neurologist who suggested that she had symptoms consistent with peripheral neuropathy. 7 months later, a repeat set of bloods were done, which still showed that she's anemic, ESR of 112, her GFR dropped to 49, and her alkaline phosphatase went up a bit to 425. The urine dipstick, it still showed leukocytes, nitrates, protein, and blood. So there was something going on. Further, 3 months later, she developed symptoms of weight loss. She lost almost 11 kg in 10 months. She developed intermittent loose stools and abdominal pain. So she had some gastrointestinal symptoms for which she was referred to a gastroenterologist. An endoscopy was performed which showed candida esophagitis, gastric and duodenal ulcer. 2 months later, she was admitted to the hospital with pyrexia, worsening lethargy, poor appetite, and weight loss. When she was investigated, she was found to be pancytopenic, and she was treated for neutropenic sepsis. She was further investigated for the cause of all of this thing, and a CT, thorax and abdominal pelvis was done, which showed mesenteric lymphadenopathy and multiple hyperdense liver lesions. A liver biopsy was done to investigate the etiology of those liver lesions, which showed anaplastic large cell lymphoma. She had an HIV test, which was positive, and then her CD4 count was low at 9. It is very, very low. She was diagnosed with advanced HIV disease. Unfortunately, she continued to deteriorate with neutrophil neurogenic sepsis. She developed multi-organ failure and unfortunately passed away during the same admission. So this lady initially presented with symptoms and investigations that were suggestive of connective tissue disease. But by the time she was tested for HIV, it was already too late. Basically, HIV infection, it shares many clinical manifestations with connective tissue diseases, which include musculoskeletal symptoms such as myalgias, arthralgias, also skin rashes, lymphadenopathy, and multi-organ involvement. They also share many common laboratory findings such as anemia, leukopenia, lymphopenia, thrombocytopenia, and hypergammaglobulinemia. And all of these findings were present in this case as well. Also, autoantibodies, they may be falsely positive in viral infections like HIV and in malignancy as well. So we have to keep this thing in mind that all autobody positivity is not connective tissue disease. Risk factors for HIV infection, they should be considered during assessment of multi-system diseases like connective tissue diseases, particularly if we are planning to start immunosuppression. And a viral screening, which include HIV test as well, they should be considered in all high-risk patients, particularly if the symptoms are atypical, as in this case, and if the symptoms are not fitting quite well with the diagnosis of connective tissue disease. I remember one of my consultants told us about system 1 and system 2 thinking. System 1 thinking is automatic and it uses shortcuts to make quick decisions, and they are often based on common sense estimates, while system 2 thinking is a more deliberate decision making using conscious thinking and reflection. System 2 thinking is much slower than system 1, and hence in emergency situations, we mostly use system 1 thinking. But system 2 thinking, it allows for an in-depth analysis of things, and it can help us prevent many inaccurate quick decisions. And this is a very good example in which system 2 thinking should have been used. Thank you very much.
Thank you for listening to that presentation. We all do need to bear in mind that lots of diseases are presenting in atypical fashions and making a comeback. Our gum doctors are telling us that tertiary syphilis is up 1,000% over the past couple of years. So we do need to bear in mind all these other diseases. And finally, for tonight, we've got Dr. Alan Zhu, who was working at Barts Healthcare Trust when they did this quality work, improving the quality of the post-take wardround documentation in an older person's service. Thank you, Alan.
Okay, thanks, Nick. So first, I'd like to thank Sam for the opportunity to present this quick project. So as you can see, it's on improving the quality of post-take ward-round documentation in the care of older people service. I carried out this project when I was a foundation year 1 doctor at Royal London Hospital, which is part of Barts Health. The reason I decided to undertake this project was that I believe documentation is very much an under-discussed part of medical practice. I think a pet peeve of a lot of us is that we go to someone's medical notes, there's no consistency, handwriting's often illegible, and I think it's a part of medical care which I think is underappreciated and sometimes neglected. Okay, so just a bit about the importance of the post-take ward round. It's often the first time a senior clinician, i.e. a consultant, reviews the patient. And because of that, it requires high quality documentation of clinical findings and especially decisions which are made during that ward round. This project being focused on older patients in particular with multiple comorbidities and complex social histories requires a certain nuance about documentation, especially with regards to things like escalation plans and resuscitation status. And despite this, there's no real guidance from any Royal College or any governing body regarding post-take ward round documentation. The RCP offered some generic guidance on ward round documentation, but nothing specific for post-take ward round. So the aims of our project was to assess the quality of documentation in the post-take ward round for the geriatric service in our acute medicine department, to standardize the content documented through development of a pro forma, to encourage the initiation of a comprehensive geriatric assessment, I'll go on to what that is later, and obviously to improve patient safety and continuity of care. So initially, the consultant geriatricians at our hospital agreed upon key information that should be documented during the post-take ward round. Obviously, this isn't a particularly fine science, but essentially they agreed upon a list of things which they felt were important to be aware of or to document during the first ward round that the consultant undertakes. And then we assessed post-take ward round documentation from Monday and Saturday of every week from 1 month to assess how much key information was documented, ensured a variety of consultants and juniors documentation was sampled, and identified any differences between weekday and weekend documentation. So, and then our specific quality improvement that we were making was to implement a post-take ward round pro forma to improve the documentation of the key information we had decided upon. So the initial audit we carried out was on 78 patients, median age is 3, and equally split really amongst male and female patients. And 8 consultants were sampled in terms of the documentation for them. So across the bottom, you can see the things we decided to audit. So generate things like name of consultant, the junior signing off, down to things like what the working diagnosis was, escalation plan, and how well the comprehensive geriatric assessment had been initiated. So I think certain key findings, only 42.3% of patients had an escalation plan or status documented. And whilst about 91% of documentation had a consultant named, you'd expect this really to be 100%. So there's room for improvement in, as you can see, a few modalities there. So this was the pro forma we decided to implement. So as you can see, it starts off fairly basic in terms of name of consultant, how the patient presented, and then moves on to sort of more aspects which are more focused on the older patient or geriatric patient, for example, the clinical frailty score, what the previous social situation was, what package of care they had, which I think are important baselines for assessing whether patients need an escalation of their package of care later on in their stay. And then basic things like observations, which I think are important for any ward round, results of any investigations, and moving on to the geriatric assessment, which is obviously more focused towards care for older patients, things like a dementia screen, a dementia delirium screening, medication reviews, etc. And then, as you can see, their ceiling of care and there's escalation status we've highlighted in red because we felt that was a key part of documentation for older patients. So then, after implementing that pro forma, we performed our audit again. This time, there are fewer patients, most likely because this was past the winter peak, but the age and gender split was pretty much the same. Again, 8 consultants were audited. And then this was the raw data that we gained. So I think key improvements, so we managed to increase the named consultant from 91% to 100%. Escalation plans, we made a big change in, so from 42.3% to 84.8%. And then documenting a working diagnosis also increased quite significantly. And this is just a cycle comparison between cycle 1 and cycle 2. So as you can see, there's been broadly an increase amongst all of these modalities. So essentially our conclusion is a basic pro forma can aid in improving the quality of documentation during the post-take ward round. It prompts for information and it's something easy to fill in for juniors, and it can remind people of key information that should be documented. So essentially next steps. So, I mean, it's nice obviously that we have a pro forma which is nice, neat and tidy, but does it actually impact on patient care and patient outcomes? I'm aware this is something which is obviously going to be difficult to analyze, especially there's so many, the geriatric population is so broad, but this is something we're looking into hopefully doing in the future. Okay, thank you.
Thank you very much for that presentation on your ward rounds. I think it's probably something I'm allergic to, but do you think that medicine by rote and checklist is the way forward, or should we still be engaging our brains on a ward round?
So that's a good question. I think there is definitely room for a mix of both. I think there are definitely things which should always be documented and are important to document, especially in the first, especially in the post-take ward round. And I think things like escalation of care, resuscitation status are always key. But as you said, of course, it's often a diagnostic process as well. But I think that's also how we can use things, as you say, checklists to help us. Things like looking through the blood results, chest X-ray results. It kind of make sure that no stone is unturned. So I think these two things can go hand in hand, so to speak.
Do you think it was a bit odd that in your first cycle, 30% of patients on a post-take ward round didn't have a documented working diagnosis?
Yes, I do find that odd. And I think, again, that's where sort of the consistency and continuity of care factor comes into place. So patients will move very quickly to a separate ward, and it'll be very confusing for people picking up a patient. So what exactly are we treating here? Which is obviously why we felt that was an important part to make an improvement on.
And for the ward round in itself, do you think your pro forma sped up, slowed down, or had no impact on how long the ward round took per patient?
So that, again, that's a good question. That's something we focused on and particularly to look at, but wasn't something we actually particularly timed. The results kind of varied amongst consultants, and essentially how committed they were to essentially filling in all the things we wanted to. The consensus was no, not really. There wasn't a change in how long a ward round took. No.
Okay. And is there any one thing you'd have changed in your pro forma?
I think things like venous thromboprophylaxis was unnecessary, because that's already, so in terms of the system we have in our hospital, that's already documented elsewhere, and I think that was broadly ignored most of the time. I think a lot of the things like lines, etc., was not particularly necessary, and I think people left empty. And I think there's obviously room for scope in terms of improving the pro forma itself, which we're looking into as well.
Okay. Well, many thanks for presenting your work. That concludes all the talks for tonight. But before we sign off, we've got some questions, more questions for you to answer. We've got another 4 quick questions in a poll. So the first closing question is, how do you now understand the insights from ISRIC and ICNARC? And that's a good improvement. Second question, the same for conscious proning. And the third question. That's good. Thank you for all those that voted. And the final question for tonight. Okay. Thank you very much for your input. Just to say that these slides will be up on the website the web link at the bottom there, www.acutemedicine.org.uk. We can find the resources and sign up for future webinars if you haven't already signed up. Next week we have two subjects. One is around the ACP acute medical curriculum. This is a project that SAMinar are heavily involved in with the RCP and HEE, designing what could be loosely called a credential for our ACPs. And then a presentation from Matinada King around acute medicine. And then finally, on the 17th of June, this current scheduled webinars, we've got the implications for acute oncology around the COVID-19 and using apps to facilitate early discharge. So many thanks again for joining us. Thank you to all the speakers. Thank you to Aventage for coordinating it, and Tim for making certain all the techie stuff went brilliantly. Thank you. Good night.